All right, thanks, Jeremy. Thanks. Good afternoon, everyone. Welcome to the session. So the topic today is an overview of important anaerobic infections. It's a really vast topic. So even with picking and choosing, there's quite a lot to cover, so we'll get straight to it. So an overview of the presentation, we're going to do an introduction to anaerobes, basically where it all began. We'll speak briefly about the anaerobic microbiome, which is an important part of the human organism in its totality. And then we'll go through some important and/or interesting anaerobes, the organisms themselves, the syndromes they cause, and a couple of principles of management, and maybe 2 or 3 slides on some of the nuances of diagnostics towards the end. So it's important that we discuss some basic definitions here so that we're all on the same page. So to start, I'm sure everyone's seen this diagram at some point in their careers. So obligate aerobes, we won't be discussing them. Things like TB as an example, they need oxygen to grow. Next in line would be capnophilic organisms. So Capnocytophagi as an example, they grow best in carbon dioxide at around 5%, which reduces the oxygen concentration to around 15%. Microaerophilic organisms, things like Campylobacter as an example, they require oxygen concentration to be reduced to 5% or less. Then you get to the more interesting obligate or strict anaerobes, things like Clostridia. Some of these are killed on exposure to even small amounts of oxygen. And then facultative anaerobes, these are things we know well, things like E. coli, they're aerobes, but they preferentially use oxygen, but they can grow in the absence of oxygen, albeit at a slower rate. And lastly, you've got your aerotolerant anaerobes, things like Bacteroides, or at least certain subspecies of Bacteroides, they can survive exposure to oxygen, but struggle with their metabolic functions. I came across this meme. You want to think of it in terms of a personality type. Well, it's the obligate aerobes. They're the extroverts. They need oxygen. The facultative anaerobes, they're a low-key introvert. They want oxygen. The aerotolerant anaerobes, they're the cool kids on the block. They don't care if there's oxygen. The obligate anaerobes, they're the introvert. They're hiding away in the corner at the bottom of the tube. They're killed by oxygen. And the microaerophils, they're the low-key extrovert. They need a little bit of oxygen. We're going to focus mainly on the obligate and strict anaerobes and the aerotolerants, purely because discussing all the others would just be too much. But those are sort of the strict definition of anaerobic organisms. So it comes down to anaerobic metabolism. Won't go through this in detail, but all organisms need energy. They either get it from light or from chemistry. And if you go through anaerobes, we know that they generally need denitrification, ion reduction, sulfate reducers. They cannot use aerobic or oxygen for the electron transport chains and things like that in order to generate the oxygen. So what they do rely on a lot is fermentation, and we know that results in gas formation, varying forms of gas, and they ferment various derivatives of pyruvic acid, propionic acid. There's a number of things that they can use as substrates, and that results in a little bit of gas being produced by the organisms as a byproduct. So the question is raised that to be oxygen dependent or not to be in an oxygen-rich world, why would anything evolve to be intolerant to oxygen? This is just a heat map of surface concentrations of oxygen at least along the water, the surface of the water. And again, we're an oxygen-rich world. So why would organisms evolve to sort of avoid oxygen? Provides energy, etc. And it's the world in which we live. So the first thing to keep in mind is too much of a good thing. Everyone has probably nightmares from chemistry back in high school. Your Lewis dot structure, these valence electrons, and the empty valence spots essentially result in reactivity. So oxygen is a reactive molecule, atom, and can form all sorts of these reactive oxidative species, things like superoxide, hydrogen peroxide, etc. Now, reactive oxygen species are harmful in many ways, shapes, and forms to pretty much every molecule that's important to a cell, be it the lipid bilayer, be it the proteins and enzymes, be it the heme molecules, be it the DNA itself. And in fact, to the point where the toxicity is such that all these organisms have had to evolve antioxidant systems purely to survive. Ones we know a lot about, superoxide dismutase, catalases as examples, and essentially every aerobic organism in the world needs to have some sort of mitigation against the oxygen toxicity that the oxygen causes in order to actually effectively use oxygen. Okay, and again, those are some of the reactions. So oxygen is, while it provides energy, it's also potentially toxic. And then you've got to go back into the history or the evolutionary history of life on Earth. So a long time ago in a galaxy not so far away, that's this galaxy, Go back about 3.5, 4 billion years. This is something like what the planet Earth looked like, at least at the beginning. On the far left, essentially, you've got fire and brimstone, surface temperatures in the 200-300s, lots of volcanic activity, a fairly inhospitable world to the development of life. But that eventually cools to an atmosphere that's very rich in methane, carbon dioxide, water vapor, this guy. And it's this environment that is essentially permissive to the beginning of life. And it's this environment, in fact, which was somewhat anoxic. In fact, oxygen concentrations at this point were less than 1%. Now, the fossil records, and we do have fossil records even for microorganisms, tells the story of the origin of archaea, the first organisms, and life essentially diversified in a world that was devoid of oxygen. So that has an effect on the catalytic strategies that these organisms use. They were reliant on methanogenesis, sulfate reduction, iron reduction, together with some degree of fermentation for their energy generating requirements. Okay, and organisms like these, in fact, still exist, essentially in every inhospitable place on Earth, deep down in the Mariana Trench or near hydrothermal and geothermal vents where it's very hot. So in all the weird, wacky, and wonderful places, you'll still find the evolutionary descendants of these organisms. But these organisms were, in fact, dominant organisms at the beginning of the origins of life, of cellular life at least. That said, what eventually happens is the evolution into cyanobacteria. Now, these guys are smart. They recognize, so to speak, recognize that solar energy is abundant. There's a lot of heat, there's a lot of light, there's a lot of carbon dioxide in the atmosphere, there's lots of water vapor, and photosynthesis is, in fact, an efficient and effective way to make lots of energy. The byproduct of this would be oxygen, which is somewhat toxic, but in fact, oxygen diffuses quite rapidly out of through sort of the lipid bilayer, and in the absence of atmospheric oxygen in high concentrations, the cells can still survive. But that leads to what evolutionary-wise was considered the great oxygenation event. Essentially, this was a geological event in which there was a sharp increase in oxygen levels because of the emergence and dominance of these photosynthetic life forms. And that leads to a major shift in the Earth's environment. And this occurs around 2.5 billion years ago. So oxygen levels rise dramatically. This displaces methane, ends an effective greenhouse effect. The Earth cools. Oxygen, water vapor settles into the oceans, it condenses, and carbon dioxide is dissolved into the ocean. The methane is broken down by sunlight into things like, ammonia is broken down by sunlight into nitrogen, hydrogen. The sulfur excess is sort of recycled back into the mantle, and the winners end up being oxygen and nitrogen. Nitrogen's fairly inert, it stays in the atmosphere, it didn't really change, but oxygen becomes much more abundant, around 21%, which we see now. And as a result of this, there's a massive shift. In fact, there's a glaciation, there's an ice age that occurs, and there's a massive shift in the organisms and what they now need in order to generate electricity. We've gone from the top over there with nitrogen, carbon dioxide, water vapor, ammonia, and methane to a lot of oxygen and a lot of nitrogen. And as that happens, basically the original anaerobic archaea or microorganisms essentially need to, in order to survive, need to adapt. And the way that they adapt, it's a number of ways. Number one, some of them took on, in a sense, some of the aerobic cells. The aerobic cells develop and they take them on, and that forms, for example, the origin of mitochondria. And as this permissive environment, lots of oxygen, which allows for slightly more effective energy production, the eukaryotes come along, bigger creatures start to form and start to evolve, and the anaerobes essentially start to become symbiotic with those, and they live either within this, they live essentially within those organisms in order to maintain their anaerobic milieu, and that sort of finds where we are today. So that brings us to anaerobes in the human microbiome. So what's important to know is that they are the predominant form of life in the human body. There's several hundred species of anaerobic organisms, essentially on our skin, in every single body cavity that is not sterile, to such a degree that, in fact, many of them are poorly characterized. In fact, because microbiology is rich on culture-based diagnostics, when trying to use sort of molecular methods to characterize the anaerobic microbiome, it was discovered that there were hundreds, if not thousands, of species that, in fact, are yet to even be characterized. Interestingly, how do they live in some of the areas where you think there is still a lot of oxygen, our upper airways, for example, around our teeth? Well, essentially, it's hypothesized that they withstand oxygen at these sites because of the presence of the aerobes, which consume some of the oxygen and reduce the oxidation reduction potential, essentially protecting them. And they also reside in the portions of those areas in which are relatively well protected from oxygen. Think of the gingival creases in one's mouth. These organisms have numerous roles and effects, including things like metabolism, primary to secondary bile acids. They have immunomodulatory effects on our mucosal immunity. They are involved in the metabolism of certain amino acids. They generate short-chain fatty acids, or at least some of them do via fermentation, which in fact can be used by our colonic cells as a form of fuel. So there's a diverse number of positives by having a symbiotic relationship with these organisms. And then probably most importantly, what they talk about in a sense is colonization resistance. By having these organisms in and around our colon, they displace potentially more pathogenic organisms. So we live side by side in harmony while they essentially protect us. But there's a number of other roles that are postulated to be related to the microbiome. And it's been shown, at least in animal models, that if you displace the obligate anaerobic bacteria, or if you induce sterility in sort of fetal animals or early life in the animal model, at least, there's a number of effects on the gut not developing the way it should. In fact, some of the things like the short-chain fatty acids, the butyrate that's produced as a byproduct of their metabolism, these things, in fact, downregulate, the absence of them downregulates things like GLP-1 and GLP-2, which can essentially result in metabolic sequelae. And there's an association between diseases like metabolic-associated steatohepatitis, or MASH, MAFLD, as it's now called, obesity, things like insulin sensitivity and type 2 diabetes. And again, it's a putative association that's been demonstrated, at least in the animal model, but the working theory is that they in fact keep us healthy in many ways, and more so than just by preventing other things taking their place. So how do the friends then become foes? Well, number one, overgrowth. If you have shifts in flora, for example, taking antibiotics, and Clostridium difficile, which I won't be discussing today for the sake of time, is a good example of that. Immune deficiency or dysregulation, which allows a more permissive environment, potentially overgrowth or dysregulation of a number of varying species and potentially invasiveness. Then I've called it wrong place at the wrong time, essentially loss of mucosal integrity, endogenous causes of that. For example, the presence of a tumor or something like that will facilitate entry of these microorganisms beyond the mucosa, which is where they're supposed to be, or an inoculation injury of any form, surgery, perforation of a viscus, etc. And then lastly, toxin production. And this is a key component in certain infections, especially clostridial infections, where they enhance virulence in invasive infections, potentially neurotoxin production in diseases like botulism and tetanus, and GIT dysfunction in localized GIT infections, like diarrheal illnesses. So a brief word on the epidemiology of anaerobic infections. And again, this is really just certainly not a holistic list of some of the disease entities, but an important one nonetheless. Things like actinomycosis caused by Actinomyces israeli, antibiotic-associated diarrhea, we've just mentioned, varying forms of bacteremia, brain abscesses or abscesses anywhere for that matter, which are often polymicrobial, infections involving the female genital urinary tract, diseases like bacterial vaginosis, intra-abdominal infections, liver abscesses, peritonitis, perirectal infections, diseases like Clostridial myonecrosis, certainly chronic oral and sinus infections associated with polymicrobial infections, including anaerobes, things like aspiration pneumonia. I'm not going to go through the next slide in detail, but looking at the reverse way, some of the associations with the organisms with the infections that they can cause. So what about what are the most common? So again, this is a fairly old paper, but it's looking at the prevalence of the varying anaerobic organisms isolated in a clinical context. Okay, and you can see that essentially your gram-negative rods, Prevotella, Fusobacterium, Porphyromonas bacteroides fragilis, makes up the vast majority on this graph, at least, or at least a big chunk. And then your gram-positive anaerobic cocci, certainly a smaller group, your Clostridia, which are gram-positive bacilli that are spore-forming, a slightly smaller group, and the other gram-positive rods, the smallest. What about locally? Again, this is from a paper from, I think, 2006. It was the most recent I could find locally. But this was just looking at least in one area or in one major lab, the anaerobic isolates over a year-long period. And again, Bacteroides sort of coming to the fore, the gram-negatives, your Clostridial species around a quarter, and then your gram-positive anaerobic cocci, making up the remainder. So fairly similar representation. So how do we break them down? How do we think of them? So a framework that's useful, it's artificial, but it's useful, is just to look through the gram stain. And let's say you've got gram-positive bacilli. Are they spore-forming, your Clostridia, or non-spore forming? And there's a number of them. Your gram stain, if it's gram-positive cocci or gram-positive anaerobic cocci. And again, there's a number of organisms that are associated with both health and disease. Your gram-negative cocci, which is a very small group in terms of what's likely significant. And then your gram-negative bacilli, which is probably the ones that we're most familiar with and certainly have isolated the most in the setting of blood cultures and things like that. So we'll go through some of these, and again, I might go through some faster than others in the interest of time. But let's start with our Clostridial species. So your gram-positive anaerobic bacilli, your spore forming. So these are anaerobic gram-positive rods. They may be gram variable, which is actually quite interesting, and potentially with older cultures and with certain organisms like Clostridium ramosum, where they may be overtly gram negative, in fact, on the gram stain. They're capable of forming endospores, which are often classified as being terminal or subterminal, and there's a malachite green stain which can identify the spore formation. And there's over 200 described species. Don't worry, we won't be discussing them all. They're often, at least your Clostridium perfringens, often described as a boxcar shape. That's this top panel over there, which is a characteristic shape which suggests potentially that disease. They're ubiquitous in nature. They're found all over the place in other mammals, in other animals, and in the soil. And most are obligate or strict anaerobes. Again, a number of the species and ways in which they can be identified, and the mechanism by which they cause disease, or some of the pathogenesis, or some of the virulence factors. Things like lecithinase being produced, which can break down barriers, various enterotoxins, various hemolysins, various neurotoxins predominantly on the bottom. You see the intoxications where botulism and tetanus, for example, do not cause major invasive disease, but it's the neurotoxins they produce. So looking at Clostridium perfringens, again, isolated from the soil, sediment, and GI tract of mammals, including humans. The toxin expression and inoculum is what dictates the virulence. So if they don't express the toxin, they may be less virulent or avirulent. Varying disease associations, food poisoning, again, ingesting contaminated meat products with often preformed toxin, so one can fall ill fairly soon after ingesting. And then what's classified as crepitant soft tissue infections. Bit of a misnomer. They don't all have to have crepitus. They certainly don't have crepitus as they start. And it's a potentially later feature. But Clostridial myonecrosis and necrotizing fasciitis, with which I'm sure everyone's familiar. And then puerperal sepsis or post-delivery, again, unfortunate sequelae from that infection and sometimes caused by Clostridium perfringens. What are the risk factors? Again, trauma, and it's especially with deep or soil-contaminated wounds, crush injuries. These were well characterized on the battlefield historically. Intravenous drug use, especially subcutaneous injections, diabetes, peripheral vascular disease with the permissive anaerobic environment that will allow, and then postpartum or post-miscarriage with retained products of conception. So myonecrosis generally will begin within 24 to 72 hours after the traumatic event or the inoculation. And the hallmark is, in fact, disproportionate pain relative to physical findings. That's the first thing to occur long before you'll have any crepitus or even be that toxic, but severe pain disproportionate to what's visible on the surface of the skin. That usually would be followed by redness and a rapidly spreading brown to purple discoloration of the skin. The progression within hours you then may have worsening edema and the gas may become apparent. They often develop hemorrhagic bullae at this point with a distinct mousy odor of the exudate as opposed to the typical putrid smell of anaerobes. Virulence dictated by the alpha toxin and lecithinase, again, toxic to polymorphs. They're often scant on the gram stain of tissue specimens, and it may in fact impair granular poiesis or the attraction of or the production of the bone marrow of the polymorphs. Hemolysin, it's one of the few infections where the fact that they're hemolytic on the agar may translate into overt clinical hemolysis. In fact, massive hemolysis in some scenarios has been well described. And one can identify these virulence factors, the lecithinase production on egg yolk agar. You see the opaque area surrounding the colony, and then the hemolysin production by Clostridium perfringens on the blood agar, and it often has dual alpha and beta hemolysis, a double zone. Fever may well be absent, and as mentioned, you don't necessarily generate the polymorph response that one would expect. Again, just going through the portal of entry, so you have the mucosal skin breach. The organisms or spores are introduced into the soft tissue, and it's the endotoxins and exotoxins that are released. These cause local tissue damage. Platelet aggregation occludes capillaries, and this damages the vascular endothelium, which results in the so-called necrotic component. And then the necrosis results in damage to your deeper tissues, and the hemorrhagic bullae, which are a manifestation of essentially multiple layers of tissue necrosis. The treatment, extensive and aggressive debridements, antibiotics. They're susceptible to most beta-lactams, but you have to consider polymicrobial infections. Toxin suppression is always suggested. Again, good trial data, I must say, I struggle to find, but it's certainly something that every textbook suggests and has a sound physiological basis. There's some resistance to clindamycin in terms of the organism itself, so that's something to keep in mind, and one can potentially use tetracyclines as a possible alternative. There's this role for hyperbaric oxygen, which again, I'm not sure has borne out in trials either. And then in animal models, the use of colony stimulating factor for the impaired granular poiesis has shown benefits, at least in an animal model, not something that necessarily is done in humans as yet. A number of other Clostridial species cause very similar types of infections or skin and soft tissue infections. Again, Histolytica monovii would be examples associated with gas gangrene. It's important to know that Sordelia is associated uniquely with injection drug users, and in puerperal sepsis, against Clostridium perfringens and Sordelia are associated. Just a couple of tidbits on some of these organisms, because some of them are quite interesting. Clostridium septicum and tertium are also associated with the presence of a GI malignancy, though they cause a similar disease entity to Clostridium perfringens. They're also associated with the presence of neutropenia and may be responsible encephalitis in patients with neutropenic sepsis. And Clostridium tertium is resistant to penicillins and clindamycin. So if that's ever isolated, you need to resort to drugs like metronidazole and vancomycin. Clostridium sordelia and Histolyticum, as mentioned, associated with puerperal sepsis. And just interestingly, Clostridium novii can appear gram-positive on the gram-negative on the gram stain. Botulism, we'll briefly discuss botulism and tetanus, just because they're important anaerobic infections under this group in terms of the spore-forming organisms. So botulism derives from the Latin word botulus, or sausage, and it comes from outbreaks in the 19th century that were derived from essentially sausages. The disease results from an intoxication with the protein neurotoxin, and this predominantly will affect the neuromuscular junction. Does affect to a much less degree than, say, tetanus, the autonomic synapses, and it will manifest as a descending weakness. There's numerous toxin serotypes, A through F, but A, B, E, and more recently F are the ones that predominantly affect humans. And this has some relevance for therapy with neutralizing antibodies. If you're going to use antibodies that neutralize the toxin itself, it needs to be type specific. And there are some clinical differences, which I won't go into, that have been characterized between the different toxin serotypes. So in terms of classification of the types of botulism, the one that I think is well known is foodborne botulism. So this is associated with certain cultural fermented products, beans, fish, and pruno, which was essentially prison wine, canned food or pickled food that's done in an uncontrolled setting. Again, often the implicated substance in outbreaks and low individualized infections. Ingestion of contaminated food is often with preformed toxin, and hence the fairly fast onset of the disease. In certain scenarios, there's unclear etiology, and it's postulated that some of these patients have achlorhydria or antibiotic use, which predispose to sporulation and colonization of the organism, and then toxin production thereafter, similar to what happens in infant botulism. So classically, this was associated with honey, although it occurs with other foods as well, but it's the ingestion of spores within a permissive gut environment to allow for their germination and then the toxin production. Wound botulism, again, inoculation with toxin absorption, less common, but well described. And lastly, with bioterrorism potential inhalational route of the infection also being something that has been described. So what's the mechanism of the toxicity? Well, ACH in the nerve terminals is packaged in vesicles, and normally these fuse with the nerve terminals, releasing the transmitter into the synaptic cleft. This process is dependent on a series of proteins, which are collectively called the snare protein. There's 3 of them. And essentially what botulism toxin does is it cleaves the snare proteins and prevents the assembly of this fusion complex to facilitate the release of ACH. And essentially you cannot activate the neuromuscular junction, resulting in weakness that is usually descending in nature. Again, just some of the clinical appearance. The classic presentation of botulism is an acute bilateral cranial neuropathy associated with symmetrical descending weakness. Some of the cardinal features that need to be noted is fever is usually absent unless there's a secondary cause, and the neurological manifestations generally will be symmetrical. The patient is fully responsive. It does not impair their level of consciousness in any way, shape, or form. The heart rate's normally slow in the absence of hypotension. It doesn't cause significant autonomic dysfunction, and there should be no sensory deficits to help distinguish it from conditions like Guillain-Barré, where there may be an early sensory component. The diagnosis is predominantly clinical. One can culture the food or stool, generally at a reference lab. It requires strict anaerobic culture. The toxin detection can be done from the patient's serum or from the contaminated samples to ascertain if they are indeed the source. And essentially, one of the seems more archaic, but they're still using it to some degree, is the mouse bioassay, where they essentially inject the presumptive, the serum of the patient or the presumptive source of the toxin into the peritoneum of small mice. And they give the mice antitoxins in various forms, A, B, and E. A, B, and E. And essentially, they watch what happens to the mice who's given the antitoxin, the mouse who's not given the antitoxin. And essentially, anyone in whom the toxin was not neutralized would pass away. But in fact, they often get this shouldering or this appearance of this. Let me just turn on the laser pointer here. This appearance of the respiratory muscles essentially struggling. You can see the 2 little mice, the one on the left fat and happy, the one on the right essentially this is respiratory muscle embarrassment, and this can be the earliest sign of the presence of botulism toxin. Important mimics for the disease, so again myasthenia gravis with the ocular manifestations, with cranial neuropathies, but the patients usually will not present as fulminantly. Diseases like tick paralysis, which is not common, but again, exposure history would be helpful. Guillain-Barré syndrome, again, the descending versus ascending weakness and the presence of sensory symptoms, which may well be present in Guillain-Barré. Miller-Fisher variants or Miller-Fisher syndrome of AIDP, that one can be quite difficult, but those patients tend to have ataxia, which can be useful to differentiate it. And lastly, magnesium toxicity, which generally would have some context to it. What's the treatment? Well, firstly, supportive. It has a much better prognosis than tetanus, probably because of the absence of the autonomic symptoms. Ventilation, if indicated, using spirometry targets to decide, not waiting for the CO2 to climb. And then, if possible, reduce toxins. So induce often prokinetics are given to remove preformed toxin. And then botulism toxin, antitoxin, if it's available, is recommended. And there's a trivalent and a heptavalent preparation. It's equine derived. There's a risk of anaphylaxis, about 1%, and it's not registered for infants. But there is, however, a human-derived orphan drug, baby botulism immunoglobulin, which is humanized, which is human-derived and can be given to babies with neonatal botulism. Does one prevent it? Well, it makes sense. Avoid contaminated foods or potentially contaminated foods, bulging cans, food preparation, being cautious if you're going to ferment your own foods, pickle your own cucumbers, etc. Outbreak response, if it is detected, it's a notifiable condition. It is heat labile, the toxin itself, not necessarily the spores of the organism, so you cook food well. And then vaccine, it's interesting that for tetanus, we have a good vaccine. For the toxin, we don't seem to have come right with botulism as yet. There's no natural immunity induced by the disease, and a pentavalent vaccine was developed, but it was found to wane very fast, and in fact was discontinued about a decade ago. And there's ongoing research to optimize vaccine response. Moving on to botulism's cousin, tetanus. So again, recognized in ancient Egyptian literature, and there's an early description which really just captures what it is: a disease of the nervous system characterized by tonic spasm, violent, brief exacerbations, almost always commences with muscles of the jaw and neck, causing closure of the jaws, and involves the muscles of the trunk much more than those of the limbs, acute in onset, and a very large proportion of those affected die. Unfortunately, that remains true. However, with the vaccine introduction, we've seen a dramatic decrease in the number of cases in most parts of the world. So Clostridium tetani germinates in low oxygen conditions, particularly in wounds. And again, in toxigenic strains, toxin production and absorption is the mechanism of disease. Not all Clostridium tetani actually is toxigenic. It is vaccine preventable. We know the vaccine neutralizes the toxin, and we still see around 300 cases a year, the majority of which are neonatal. Mortality is still pretty high, between 10 and 40%. The organism itself is ubiquitous. It's more commonly found in manured soil. The spore form is incredibly stable in the environment. It can last for decades. To kill it requires autoclaving under high pressure at over 100 degrees. It's resistant to formalin and alcohol-based disinfection, but it can be inactivated by peroxide and iodine. It's a gram-positive rod with this racket shape, the terminal spore form, which is well described, and in older cultures may well be gram variable. The pathogenesis, again, tetanus spasm or tetanus toxin, it's incredibly similar to botulism in the way that it works. The big difference is this retrograde intraxonal transport, which essentially takes it from the neuromuscular junction, being the site of disease entity, to rather at inhibitory interneurons within the central nervous system. Together with the autonomic nervous system. And they develop marked autonomic instability, and that's often contributes towards the high mortality. There's four forms as well: generalized, localized, cephalic, and neonatal. And the description generalized, I think, as we all know, with early trismus and the rhizus sardonicus, spasm of the facial muscles with generalized spasms and opisthotonus subsequently. Localized, which is often in smaller inoculums or in partially immunized patients, where they'll have muscle rigidity limited to the site of the spore inoculation. Cephalic, and this usually forms tetanus. Again, it's a form of localized tetanus where the inoculation injury is sort of on the head or on the head and neck, or after a head injury. And then neonatal generalized tetanus in newborns, which is usually a result from infection of the umbilical stump. So again, as a clinical diagnosis, there are some differentials that one needs to consider. Strychnine poisoning, again, there'll be context, dystonic reactions. Again, one would want to check for underlying neurological conditions or drugs that can induce those. Localized causes of trismus, for example, infections. And one can theoretically exclude previous immunization by checking for antibodies against tetanus toxoid, sorry. The typical appearance of a patient with trismus and rhizus sardonicus, and some of the presenting features on admission for non-neonatal tetanus: trismus, muscle tension, dysphagia, infrequently with dyspnea, but certainly frequently with body spasms, and they often have an increased body temperature as a function of the spasms themselves combined with the autonomic dysfunction. There's an established grading system for severity, which I'm not going to go through, but know that it does exist. It's called the Ablett classification for severity of tetanus. Again, principles of management, so prevention of toxin uptake, so give the antitoxin. There's no natural immunity. So antitoxin administration to try and neutralize preformed toxin if available. Antibiotics to try and reduce toxin production within the original wound. Meticulous cleaning and debridement for the same reason. And occasionally one can actually demonstrate the organism on microscopy and culture. Muscle spasm control, which may require anything from benzodiazepines to full-blown neuromuscular blockade and intubation. Supportive care, again, in for the long haul. These patients generally will be in ICU for several weeks, and convalescence can take as long as 6 weeks. Treatment of the autonomic neuropathy symptomatically, so if they've got tachycardias, then beta blockade. It's been shown for the labile blood pressure that magnesium sulfate can help, and immunize the patient towards the end of their illness, ideally every decade in adults, and certainly post-exposure prophylaxis, and in these patients, because there's no natural immunity, to immunize them. Again, I'm not sure if we have access to it locally, but certainly the CDC guidelines promote the tetanus immunoglobulin in routine wound management in patients where you have an unknown or less than 3 previous doses of tetanus and they've had a significant wound. they would recommend not just the tetanus toxoid vaccine, but tetanus immunoglobulin. Whereas if you've had 3 or more doses, ideally within the last 10, ideally at least one within the last 10 years, then it's recommended that you don't need anything further. So let's move on to the next group. So your non-spore forming gram-positive bacilli. And again, there's a number of them, and I'm certainly not going to go through all of them, just some of the more interesting ones, and we'll briefly touch on them. So Cutibacterium or Propionibacterium acnes, again, well-described commensal of the skin, likes the anaerobic environment that's found within the hair follicle, within the sebaceous glands. And that's through that association where some of the subspecies associate with worsening cases of acne. It's an important pathogenicity is essentially related to either inoculation into a sterile site or specific localized imbalances of the varying subspecies of Cutibacterium that exist as commensals. And again, some of the associations, certainly acne vulgaris is well associated with this disease. Implant-associated infections or prosthetic joint infections, most commonly the shoulder because of the proximity to sebaceous gland secreting skin and the hair follicles that are likely to harbor this organism. And then there's putative associations with sarcoidosis, degenerative disc disease, and potentially even prostate cancer, although these are more associations than or correlation than the disease truly causing it. Actinomyces, an interesting one to discuss or touch on briefly. So again, gram-positive branching bacillus is what would be described on the gram stain. And the name comes from this appearance. It actually means ray fungus. It is not a fungus, it is a bacteria. But because of the branching filamentous appearance, the name was given actinomyces. The pathology always relates to it being in the wrong place at the wrong time. It is a normal commensal in various parts, and various species tend to colonize different parts of the human organism, the mouth, the pharynx, the genitourinary tract, and essentially its inoculation, or if it finds its way into a previously sterile site, that it could cause disease. For interest, it grows in these intriguing molar-shaped colonies on blood agar, the propensity to form what are termed sulfur granules, which are essentially matted conglomerates of the organism together with a host immune response surrounding it. And these often can be on histology or culture might be a way to make the diagnosis. And again, the histological appearance of a sulfur granule with the matted organism staining with the surrounded eosinophilic material, which is termed the Splendor-Hoopley phenomenon. So I'll touch on 3 of the different types of disease that this can cause. The most common is cervicofacial actinomyces. So this typically is a chronic, indolent, slowly progressive mass, which evolves into multiple abscesses or fistulae, draining sinus tracts that come and go. It's been nicknamed lumpy jaw disease. You can see why. And less commonly, acute suppurative infection with a rapid progression to abscess formation. Short-term antibiotics will improve the appearance, and unfortunately, that's one of the problems and pitfalls of the diagnosis, that it'll get better after a short course of antibiotics, but it will tend to recur if the duration of antimicrobials is not long enough. It can involve the bone, can cause chronic osteomyelitis, and often can be confused with malignancy. Abdominal pelvic actinomyces, so this would be an example of IUCD associated within the womb, within the uterus. So again, pelvic, IUCD associated. If it's left in for too long, each form of IUCD has a prescribed lifespan, and it's a recognized complication of leaving them in for too long, potentially, or the initial inoculation into the sterile environment. And the other way this can happen is from any sort of seepage of perforated visci. So, for example, an appendicitis with a little bit of the organism making its way into the tract, and because of the slow, indolent way in which it grows, remote from the original perforated viscus, several months, even years later, have been described, one can develop sinuses that drain through the abdomen, abdominal pain that can be confused with malignancy, with inflammatory bowel disease, etc. And then lastly, thoracic actinomycosis, again, around 15% of cases, likely always represents an aspiration event. Indolent, slowly progressive will often include or involve a combination of the parenchyma and the pleural space, potentially can cause empyema necessitans or an empyema that breaks through the chest wall. And it can mimic carcinoma, again, in radiological appearance, certainly, and in progression of disease. The treatment principles are Again, where debridement is needed can be considered, but antimicrobials, it's a very sensitive organism. However, it's resistant to metronidazole, which is important to stress, given it's our go-to for anaerobes. But it's very susceptible to penicillin, to beta-lactam, beta-lactamase combinations, but they require prolonged antibiotics, usually between 3 and 6 months, sometimes longer, to achieve true cure. Lactobacillus, again, ubiquitous in certain mammals and the environment. They ferment carbohydrates into lactic acid as a major endpoint. And again, we know this from the effects, which are intentional and sometimes unintentional, and all sorts of dairy products. Certain species form part of enteric flora and the female genital urinary flora, where they maintain an acidic pH within the vagina. And dysregulation of that can result in bacterial vaginosis. The GIT benefits include colonization resistance. And again, there's a couple of other benefits that are thought to be associated with being colonized with these organisms. However, and as such, they're often the basis of probiotic preparations. However, they are a rare cause of infection, and there's certain risk factors which have been associated, essentially mucosal barrier breaches, significant previous antibiotics, and varying states of immunocompromise would be the summary. Again, not common, but this was a three-year case series looking at all the cases in the described literature. So this was just published cases of this entity causing invasive infection. And you can see endocarditis, bacteremia, and some of the associations include post-dental procedure, again, given that it may be flora of the mouth, and treatment with probiotics in at-risk patients, usually neonates, which led to a withdrawal of the suggestion that they should be used in an ICU setting. And again, this association was proven in at least one study looking at number of cases of lactobacillus bacteremia in an ICU setting, and actually correlating the probiotics these patients were given to the recovered organisms from the bacteremia, and genome level analysis identifying that these were indeed the same organisms. And again, that leads us to the discussion on probiotics, where given their frequent usage therapeutically to prevent diarrheal disease with antibiotics, you need to think of the risk benefit on the use of probiotics. So there was a Cochrane review in children, I think about 5 years ago, which came up with a number needed to treat of around 9 children with a confidence interval of 7 to 14 to prevent 1 case of antibiotic-associated diarrhea. And they graded the level of evidence as moderate. So there's some benefit in terms of symptoms, shortens the median duration of antibiotic-associated diarrhea. Now, we're not talking about C. diff necessarily. We're talking about the diarrhea that often occurs because of dysbiosis. But again, in children, at least there's some evidence that there is a benefit. But there's also all these observational studies showing the potential for harm in at-risk patients, and lactobacillus rhamnosus being the most pathogenic that's described in the most cases of invasive bacteremia. So the suggestion is to avoid using probiotics in at-risk hosts in an ICU, in a surgery, in patients with GI pathology or immunocompromise. So probably not the best thing to do in many hospitalized patients. Regarding treatment, most are intrinsically resistant to aminoglycosides, ciprofloxacin, Bactrim, as many anaerobes are, but most are susceptible to penicillin, beta-lactams, and some to tetracyclines, linezolid. However, they can acquire resistance to clindamycin and tetracyclines, amongst others. So in vitro testing is important. What about other associations for non-sporulating gram-positive anaerobic bacilli? So bifidobacteria, I almost think of them similar to to the lactobacilli we just discussed. They're part of the normal flora. Some probiotics do use them. There's a clear implication in the pathogenesis of dental caries, and they're a rare cause of invasive bacteremia. Again, some of those are associated with probiotic use. Mobiluncus, Atopobium, these are entities that are implicated in bacterial vaginosis. Ergothella, which is an interesting name, in a compromised GIT mucosa, probably as a part of polymicrobial infections, they can cause quite a nasty bacteremia, and it's an emerging pathogen with a high mortality, 40 to 50%. Eubacterium, again, human oral commensals, which have been implicated in human bite wounds, so something to be aware of. Okay, we'll move on to the anaerobic gram-negative bacilli. Now, these are the ones with which I think many of us are most familiar. Bacteroides, Prevotella, or Pheromonas and Fusobacteria. And so I'll discuss them briefly. These account for the vast majority of identified anaerobic infections, but what's important is that they are less fastidious than many of the gram-positive anaerobic cocci, as an example. So there's a bias towards identifying these organisms. Manifestations include things like abscesses, intra-abdominal, lung, brain, dental or genital urinary, skin and soft tissue infections, especially polymicrobial, head and neck infections, dental or chronic osteomyelitis media, sinus infections, especially of the chronic modality, and less commonly they're associated with things like osteoarticular infections, peritonitis associated with peritoneal dialysis in one series 2.5%, and endocarditis in around 1%. So Bacteroides as a species, they're a genus of gram-negative, non-spore forming, obligately anaerobic rod-shaped bacteria. There's over 30 species that have been recognized, and again, they can be quite pleomorphic in terms of how they appear on gram stain. And they're the most common cause of anaerobic bacteremia is Bacteroides fragilis. Again, carries quite a high mortality if you do identify this organism, and most often associates with some form of intra-abdominal pathology. And it's often as part of a polymicrobial infection or abscesses. There is at least one unique toxigenic strain which can cause a simple gastroenteritis as a result of toxin production. They're an important part, however, on the flip side of the human microbiome. They're key in colonization resistance and displacing more pathological organisms. Several of their metabolic byproducts are important for overall maintenance of good commensals and gut health. And dysbiosis has been shown to be associated with inflammatory conditions, especially inflammatory bowel disease. They produce a number of polysaccharides. They're encapsulated organisms, A through H, with varying functions ranging from immunomodulation to facilitating abscess formation. And polysaccharide A is one of the best studied and characterized, and it's interesting in terms of a light and dark side. This colonization, resistance, immune system development, it in fact upregulates IL-10 to some degree, which essentially acts as an anti-inflammatory within the gut. And this facilitates immunological tolerance and is supposed to be important for priming the immune system towards not being overactive in the gut. On the flip side, if they do find their way into a sterile site, these same virulence factors essentially facilitate antiphagocytosis, induction of abscess formation, and allow them to become invasive. The other Bacteroides species I'm going to discuss is Bacteroides theta iota omicron. I chose it purely because the name's so interesting and weird. The name comes from the fact that this pleomorphic appearance can in fact resemble many Greek letters. There's theta, there's iota, and there's omicron. Again, not going to go through this in detail, but just important to know that it's usually an important commensal, and the symbiotic lifestyle in the human gut, again, facilitates things like digestion of certain polysaccharides and host glycans, and in fact, it promotes gut health in many ways, shapes, and forms. Moving on to the other two, and they're often put together, previously considered parts of Bacteroides, but now separate, Prevotella and Porphyromonas. So these are found in the GIT, the genitourinary tract, and the mouth. They're characterized by pigmentation production, although it can take up to a week to appear this black in culture, and this brick red biofluorescence, which is a result of porphyrin production within the cells. They're implicated in aspiration pneumonia, abscesses, again, chronic head and neck infections, oral abscesses, bite wounds, both human and animal, dog bites and cat bites associated with both of them, in fact, and the formation of brain abscesses. Fusobacterium, again, I'm going to just do 2 slides on. It's an obligately anaerobic filamentous gram-negative rod. It forms these irregular colonies on blood agar, which can occasionally be described as fried egg appearance. I know we mainly associate that with mycoplasma. The morphology varies from coccoid pleomorphic spherules like Fusobacterium necrophorum to rod-shaped and arrayed end-to-end like Fusobacterium nucleatum. You can see these sort of really prolonged, almost branch or filamentous appearance. They can be hemolytic on blood agar, and some species can cause hemagglutination, which is important for their pathogenesis. But they're a rare but well-described cause of serious human infections. So culture-negative tonsillitis, often with a membrane, that may result in more serious sequelae we'll discuss. Vincent's angina, so again, acute necrotizing ulcerative stomatitis, gingivitis, or periodontitis, which was also termed trench mouth. It's related to polymicrobial overgrowth. It's a synergistic infection of the fusobacteria and certain spirochetes within the mouth, and associated with poor hygiene, poor dental hygiene, smoking, immunocompromise. It's an HIV/WHO3 classifying disease, and likely the combination in World War One of poor oral hygiene on the front lines, relative malnutrition, lots of smoking, and emotional distress resulted in the appropriate milieu for development of the disease. But we often associate fusobacterium with Lemire syndrome. Now, Lemire syndrome was described in 1936 through a series of 20 cases of anaerobic post-anginal Vincent's angina sepsis. Basically, in 20 patients with a history of a recent oropharyngeal infection caused by what was then termed Bacillus funduliformis, now Fusobacterium necrophorum, with resultant thrombus of the internal septic thrombophlebitis of the internal jugular vein, and subsequent embolization of septic emboli and a sepsis-like syndrome. The lipopolysaccharides are endotoxins. They're important virulence factors in an animal model. Inoculating an animal with a virulent strain causes venous thrombus from formation and can lead to a septic thrombophlebitis. It presents as a pharyngitis, tonsillitis, often disproportionate and worsening neck pain and worsening sepsis. This can complicate with septic emboli, pulmonary abscesses, empyema, and brain abscesses with high mortality. In older patients, the initial oral manifestations of the infection may well have gone missed, and they may just present with unexplained septic pulmonary emboli or pulmonary abscesses or brain abscesses. Treatment suggests prolonged antibiotics, 3 to 6 weeks. Again, no good trials to demonstrate this. This is expert opinion. Surgical drainage of collections as indicated, and anticoagulation for the septic thrombophlebitis is fairly contentious but often used. The last association with fusobacterium, and this is one where it's really not so clear if it's a cause or an effect, but there's a clear association with a more virulent form of colorectal cancer in patients who are colonized or found to be colonized with Fusobacterium nucleatum. And again, it's one of those scenarios where it's unclear if it's the dysbiosis that led to the Fusobacterium colonizing, which led to which was caused by the malignancy itself, or in fact there's some degree of causation, but it's certainly there's a strong association to the point where it's been used in some studies as a prognostic marker. So how do we identify these organisms in the lab? Again, they all have unique antibiotic susceptibility patterns to penicillin, vancomycin, colistin, and kanamycin, so that can be helpful. The presence or absence of growth in bile-based agar, like for Bacteroides. Pigment production, again, your Prevotella and your Porphyromonas, and then the brick red fluorescence, which is certainly pretty to see, again, associated with Prevotella and Porphyromonas. Modern techniques, there are cards for anaerobes for things like the Vitek. There's an API that is designed specifically for anaerobes. Yeah. So again, there's a number of modalities to make a definitive identification. And treatment, again, they're generally fairly susceptible organisms to the conventional antibiotics one would consider in an anaerobic infection. Just for Bacteroides, what's important to keep in mind is that clindamycin is variably resistant. So again, if that's being used for so-called anaerobic cover, to keep that in mind. And again, susceptibility to stock standard penicillin and potentially aminopenicillins, also not guaranteed, more common in Fusobacterium species. Apologies. Okay, the last group, anaerobic cocci, which is the smallest group we'll discuss, although they may be well underrepresented. So your gram-positive anaerobic cocci, things like Peptostreptococcus, Anaerococcus, Peptoniphelus, which is a more recently taxonomically defined subset from Peptostreptococci, Parvomonas, and Feingoldea, which I've almost included also just because the name's so interesting. And then your gram-negative anaerobic cocci, Villianella, is the one that's most closely associated with less disease, more just colonization. Okay, so they're a relatively understudied group. The most common species of anaerobic cocci isolated from various types of clinical specimens is in fact Feingoldea magna, but again, it may represent that that's one of the more pathological. Parvomonas, Peptoniphelus, Peptostreptococcus, Anaerobius are much less frequently isolated, and some of them are quite difficult and fastidious to grow appropriately. There's been major taxonomic revisions, as there always are, which complicates the classification somewhat. And molecular methods, at least, have shown that they're likely much more common than previously thought in polymicrobial infections with other identified facultative anaerobes and aerobes. So in an abscess, you may well have some of these, you may just not find them. Again, just a brief 1 or 2 lines on some of them. So Peptostreptococcus, the pepto comes from the fact that peptone is an important metabolic substrate. It speaks towards the fact that it can be more difficult to grow or fastidious. And many original species from the Peptostreptococci have been transferred to alternative genera. It's implicated in abscesses of various anatomical sites, be it surgical infections, diabetic wounds, which is an important one, and various bite wounds. And there's a possible signal of increasing metronidazole resistance within this group, so something to keep in mind. Peptonophilus, so it's an important cause of biofilms in chronic ulcers. And this is something you will, if you look for it, very frequently find in diabetic, decubitus, and venous ulcers. Whether it's truly a commensal, a pathogen, or just an opportunistic synergist is not so clear, although it is occasionally associated with deeper infections involving bone and joint. There's variable resistance to some of the commonly used antibiotics for anaerobic infections. Again, Clinda up to 20% and penicillin 10%. Anaerococcus, isolated infections involving the female genital urinary tract, dental abscesses, polymicrobial infections. Parvomonas, again, it's the most prevalent gram-positive anaerobic coccus in the mouth and is associated as such with dental infections. And as such, it can be found in odontic origin brain abscesses. Legionella, the only gram-negative anaerobic cocci I mentioned, it's an oral commensal, and again, it's occasionally implicated in bacteremia and endocarditis. However, it's pretty rare. Lastly, Feingoldea magna, which was named for Dr. Sidney Feingold, was a doyen of anaerobic microbiology. It's the most pathogenic of this group, and it has numerous virulence factors, things like peptostreptococcal albumin binding protein, an adhesion factor, substance like proteinase, and all of these facilitate invasiveness and or survival during the course of infection. It's as unusual for anaerobes, it's one of the few that can cause a monomicrobial infection. It causes wound, soft tissue, and bone and joint infections, and there are described cases of endocarditis. Again, it's one of the principal and thought to be pathogenic species now in diabetic venous and decubitus ulcers. There's less doubt whether or not it's purely a commensal. And case series of anaerobic bone and joint infections found that Feingoldea was present in 21% of the cases, all of which were polymicrobial and all of which involved the lower extremities, especially the ankle. And there's increasing evidence for Feingoldea as the causative agent in certain implant-associated infections. So how do we treat the anaerobic cocci? Again, thankfully, most of them are still fairly susceptible. Penicillin, the MICs do range for Peptostreptococcus and Peptonophilus. So again, the high MICs may well be resistant, depending on the breakpoints that are established. And again, clindamycin, just the variability in more recent data in terms of susceptibility of these anaerobic organisms. So again, as much as it's a stalwart of our anaerobic armamentarium, it is something to keep in mind that without in vitro susceptibility data for the particular isolate, we may be missing a degree of resistance. So in summary, for antimicrobials in anaerobic infections, the ones that are nearly always active, metronidazole, okay? However, it's inactive against Strep milleri. Again, that's more your facultative anaerobes. Propionibacterium and actinomyces, important to keep in mind. You're usually active, again, clindamycin. However, as mentioned, your Bacteroides group and certain Clostridial species are resistant, and there's growing resistance in your gram-positive anaerobic cocci. And your Kefamycins, which we don't really use much, but again, a degree of up to 15% resistance in that group. Cephalosporins, again, we'll shy away from in anaerobic infections because of limited data. And then those that have almost uniformly poor activity against anaerobes, aminoglycosides, Bactrim, and as triennial monobactums. Okay, just 2 slides on diagnostics, and then we will be done. So firstly, collection and culture specimens to isolate anaerobic organisms is much more complex than for aerobic organisms. Inevitably, there's some oxygen exposure, or almost inevitably, in the process of trying to obtain a specimen. And this can preclude or hamper growth, especially if you're stricter anaerobes, those that are not aerotolerant. So specialized collection techniques are recommended. Certainly use specific anaerobic blood culture bottles. Specific transport media are suggested. Avoiding contamination of the samples with less fastidious organisms, because this will often obscure the growth of the target organism. Commonly, these are polymicrobial, so again, that inhibits the identification of everything growing on the plate, especially when you're growing a real zoo. And then there's this bias towards the idea of the less fastidious anaerobes, like Clostridia or gram-negatives, like Bacteroides, which again often hampers identification of the entire polymicrobial milieu. So certain sampling techniques that have been suggested for open wounds, a deep aspirate, sort of maybe less oxygen exposure, tissue biopsies at the advancing edge rather than just the necrotic tissue in the center. For closed abscesses, again, a deep needle aspirate close to the border, again, conceptually trying to avoid just taking necrotic tissue and trying to get something that actually still has viable organisms. Definitely avoid swabs. I don't think I need to tell anyone that, but they're porous, that allows oxygen in, they're prone to desiccation, these are fairly fastidious, and you'll unlikely recover an anaerobe from within a swab. Sulfur granules, if you're dealing with things like actinomyces, are useful for both culture and histology. Tissue cultures, again, debridement and skin contamination are paramount, because otherwise something else that's easier to grow will likely grow. And sufficient volumes, again, goes without saying, need to be taken. Some of the suggested additions when trying to isolate anaerobes is to try and use an anaerobic transport media. These are oxygen-free transport tubes or vials with pre-reduced and anaerobically sterilized anaerobic media. If those aren't available, which they often wouldn't be, things like Stewart's Carrie Blair, which we saw around, for example, around the cholera outbreak, Amy's transport media, blood cultures in anaerobic bottles, these can improve your yield or your likelihood of recovering the anaerobes that are involved in the infection. The specimens should be inserted deep into the media if you are going to send them off. These samples should not be put in the fridge. It actually increases oxygen diffusion, so you're more likely to kill the anaerobes before you can culture them. And ideally, if you're going to send them without one of these transport media, ideally it gets to the lab and is plated up within 1 to 2 hours. Not for blood cultures necessarily, but for the other tissue specimens and the like, and pus. With an anaerobic transport media, assuming it's done correctly, you can accept up to 48 hours is the recommendation. There are fancier toys. You must advise the lab that you suspect an anaerobe, because they're going to do things that will help identify it quickly. So gram stain with characteristic morphology can suggest specific etiologies. Fusobacterium, we saw the way it looks, that sort of long shape. Bacteroides fragilis, for example, Clostridium perfringens with the boxcar shape. So again, there can be clues and cues on the gram stain at the get-go. And then the lab will decide based on specific agar choices, but things they often use are enriched horse or sheep blood, Bacteroides bile esculin, if you're worried about Bacteroides, kanamycin, vancomycin, laked blood agar, which can be useful for recovering and identifying the susceptibility patterns of other anaerobes, especially the gram-negatives. Your press media, which is again this pre-reduced anaerobically sterilized media, which again it's more expensive, but it sort of it prevents oxidation of your samples. The use of thioglycolate broth is often recommended to recover these. And again, there's even fancier things like the oxydish, which essentially removes oxygen from the medium in the space above the agar after inoculation and maintains the anaerobic incubation. So you could use these in a scenario where you didn't have an anaerobic incubator. But normally you're going to need to use something to prevent aerobic exposure. So anaerobic chambers
available. We're going to need to end there. Do you want to maybe just summarize at the last bit? Sorry, we've just gone over time quite a bit. Is there? Okay. Are you almost there?
No, almost there. Literally the last slide, I think.
Cool. Go
so
for it, yeah.
Again, anaerobic jars for incubation vary in the complexity, from things as simple as lighting a candle in the jar just to consume the oxygen, to sort of catalysts that promote oxygen consumption, to essentially devices that literally suck up the oxygen. Quality control, you should use something within the tube that confirms you achieved appropriate anaerobic environmental conditions, and generally don't open them excessively to expose the organisms to oxygen. The problem is antimicrobial susceptibility is comparably complicated because you need to maintain this in order to facilitate growth. But the ID of the organisms that are recovered is as per standard. So in conclusion, again, these are descendants of the first forms of life and have adapted to be active symbionts making up the majority of the human microbiome. The infections are usually polymicrobial and result in disruption of mucosal surfaces or the presence of ischemia to promote the anaerobic environment. Commensal anaerobes are implicated as crucial mediators of physiological, metabolic, and immunological functions. And despite the number of anaerobic species represented in the normal human microbiota, relatively few are involved in human infections. Certain pathogens' role in disease, certainly underappreciated because of their fastidious nature and the common response to standard antibiotics. They're just never recovered. Isolation requires appropriate methods for collection, transport, and cultivation. So you really have to think of these organisms if you want to recover them. And broad antimicrobial covers always suggested a strict anaerobes rarely cause a monomicrobial infection. And while some drugs remain the stalwarts of treatment for anaerobic infections like metronidazole, clindamycin, beta-lactam, beta-lactamase inhibitors, you need to consider intrinsic resistance, for example, actinomyces and metronidazole, and the ever-evolving resistance to drugs like clindamycin, carbapenems, and levofloxacin, which is more increasingly being described in these organisms.